I want to invite to the stage our morning keynote speaker, our new regional director of the U.S. Department of Health and Human Services for Region 10, Mr. John R. Graham. Let's give him a round of applause. Thanks, sir.
Thank you.
Welcome.
Thank you.
So first, some housekeeping. Region 10 is what?
Region 10 is the 4 great states of Washington, Idaho, Oregon, and Alaska, plus the tribes, 273 or more tribes.
Wow.
More tribes than anywhere else in the country.
Yeah.
So big region.
So tell us about you. A lot of people haven't had the chance to get to know you yet. Give us a sketch of where you come from.
Sure. Well, I come from Canada.
Well,
So I'm an immigrant.
Let's start with Canada.
So I immigrated from Canada in 2005 from Vancouver, BC. And I moved down to San Francisco, and I was working in economic research at some nonprofit free market think tanks. And then I moved back east in 2012 to the DC area to the Vice President of Policy at AdvaMed, which is the Device Makers Trade Association. And I did that, then went back to the think tanks. You might remember an effort we had to repeal and replace a certain legislation. So I was involved, in that. And I got hired into the department by Dr. Price when he was our secretary on April Fool's Day 2017. And I worked back in the Department of Health and Human Services at the head office for 1 year as the acting assistant secretary for planning and evaluation. And then on April Fool's Day 2018, I got assigned out here to be the regional director.
Yeah. Are you sensing a trend about getting assigned jobs on April Fool's Day?
Yeah, I'm sensing a trend, but it's exciting. Personally, it's exciting to get back out west, coming from Vancouver, BC, and from San Francisco, so it's great to be out west. But, this job is also a stepping stone, DJ. Previous office holders of the regional director job include the insurance commissioner, Mike Creedler, and the governor, Jay Inslee. So
you're already
keep an eye out on me, yeah.
You're already thinking about your electoral career.
Thinking about the next, yeah.
Yeah.
No.
So tell us what you make of this time in health policy as the regional director, different from when you were working in DC, because I think the politics of this time are tricky, and particularly in healthcare. What are some of your observations of that question?
Well, maybe I should answer by addressing the context of the 4 priorities which Secretary Azar has brought forward. And we have 4 priorities, all of which are approved and directed by the President. One is addressing the opioid crisis. Second is affordability of health insurance. Third is shifting to value-based reform. And finally, lowering the soaring cost of prescription drug prices. And we have a number of reforms on all those fronts, some of which depend on rulemaking, some of which will depend on congressional action, all of which depend on stakeholder buy-in from all the participants in the system. Not necessarily, obviously we have critical comments to make about many stakeholders, and we insist that many stakeholders need to change. But, one of my roles is just to get out here and listen to stakeholders and understand your perspective and keep learning.
Mm-hmm. Sort of walk us through a little bit of the administration's approach on opioids first.
Sure.
What should we be watching there?
Well, so opioids within, if you go back to, I can't remember the date, but there's a presidential memo on opioids from a few months ago in which he authorized and demanded that the secretary declare a public health emergency, which is continuing, and directed all other departments of the federal government to cooperate with us on addressing the opioid epidemic. So there are 5 pillars of addressing the opioid epidemic, not all of which may be relevant to this group. One of them is more on research and development, but the others address better access to opioid overdose reversing drugs, better data on the scope of the epidemic and treatment, better prescribing practices. And one of the things I've been doing that's quite exciting, I was able to, had the privilege of going up to Alaska and doing a tour with the Surgeon General, Dr. Jerome Adams. And we had some very interesting events up there, and I'd love to replicate those events down here in Washington and the other states. We had a town hall meeting with state, federal, and local partners, including the law enforcement, Anchorage Police Department, the state troopers, other and folks on the healthcare and human services side, which was a great thing because the Surgeon General put out an advisory a few months ago on naloxone. We should all learn how to administer naloxone, identify someone who's suffering from an opioid overdose, know how to identify that, administer naloxone. And it was exciting to see the Alaska State Troopers are all trained up on that, and they are all carrying naloxone in their patrol cars, and they've actually had evidence of pulling people back from suffering from an overdose. One of the things about that I'd love to get the input from folks here. Yesterday, I was at City of Spokane Community Housing and Community Services and talking to them, and I know there's an opioid task force here in the city and county, and I've started to reach out across the department. So my colleague at HUD, we recognize housing and homelessness is a big problem in this opioid epidemic. And so within the scope of the President's directive, we're reaching out to HUD. And my peer at HUD is Jeff McMorris, who's a relative of someone you've got coming to speak at lunch, I guess.
Rogers' brother.
And so we've actually started doing some tours together to talk about how we can integrate the healthcare and homelessness. In HUD world, they call it continuum of care. So again, we're just continuing to learn from stakeholders on the ground how we can best streamline and make our processes more efficient so that people in the communities can actually deliver care and human services better. The person who leads the opioid initiative within the department is Dr. Brett Giroir, who came from Texas. He's the acting assistant secretary of health. He's a pediatrician by specialty, also a very successful physician executive and entrepreneur. And he's continuing to develop how the departments will work better together. And it takes up a lot of our time, and we all see in these communities how devastating it affects. And it doesn't seem to care whether you're urban or rural or what your income level is. I mean, there are obviously data, but it hits everybody. And there are a lot of, I don't want to ramble on, but there are, every division within HHS is working to address this, including, say, for example, the FDA prioritizing the development of non-addictive opioid withdrawal drugs. They approved one a few months ago, and if I tried to pronounce the name, I'd pronounce it wrong. But we're also looking at a pathway to moving certain products over the counter, maybe naloxone if some manufacturer has an innovative proposal to go to the FDA to say they want to supply naloxone over the counter. The FDA will be open to looking at that.
How about the other plank of the administration's approach on healthcare, this drug pricing transparency?
Yeah.
What should we be keeping our eyes open for?
Well, so keeping your eyes open for a lot of things going on. We're addressing drug pricing through a variety of ways, and I'm excited to see you've got pharma here sponsoring. Is there an important solution to the part of the solution? As you know, Secretary Azar was an executive at a large research-based drug company. I believe he was on the board at pharma when he was the CEO of that drug company. He has seen the level of attention and frustration directed at drug companies over the past decade or so. And he agrees much of this is legitimate, driven by bad behavior, runaway price increases, and market manipulation. It's frustration with a broken system that places shareholders and inside actors before patients. No single actor in the industry deserves the blame for this. Pharmaceutical manufacturers have chosen runaway drug price increases. But those increases are in part driven by incentives created by pharmacy benefit managers, distributors, employers, insurers, and government programs. Historically, generally, the main path proposed to address this problem is more government control, more restrictions on patients, and weaker incentives for innovation. That is not the way the President wants to go, and it's not what we've described in our drug pricing blueprint. And I'm happy to go into more details on that if you want.
Well, sure. How do we bring downward pressure on costs in pricing in pharmaceuticals, and how do we bring transparency without additional government intervention?
Right. Well, we've done we have a lot of ability to do stuff with some of our programs, right? Like Medicare and Medicaid and other government programs. We do intervene in drug pricing. We're hoping that our ability to influence the employer-based system is to some degree through, I'd say maybe moral suasion might be a term. We did see some of the companies, including, if I name one, I have to name them all, so I won't name one, but there were some price increases announced by major research-based drug companies a few months ago, and when the President and Secretary made public statements asking them to roll them back, they rolled them back. So we're even seeing some moral suasion, which will have some systemic impact. We're focusing on the programs we control, and hopefully that will have a knock-on effect in the broader, employer-based system and elsewhere. And you want me to describe a couple of them?
Well, let me leave that for the audience
Sure,
if they
okay,
want to
sure.
ask. Let me ask you sort of this more personal question, which
Yeah.
is your job, as you know better than anybody, is constrained by the fact that you've got to go out into communities
Right.
and either win accolades in
Yeah.
states that support the administration or take
Yeah.
the punches in
Right.
states that don't, and that you're constrained to represent the administration rather
Yeah.
than what you think, maybe
Right.
per se.
Yeah.
Is that a constraining
No.
role for you?
No?
Is it relatively straightforward?
Yeah, it's completely straightforward.
Yeah.
No, I go way back on, all these health reform issues. So, we have a big agenda, and, we're not going to cover the whole thing in the next 30 or 40 minutes.
Yeah.
But, no, it's great. I mean, it's hard to answer that question without kind of making a vague rah-rah comment, but the steps we're taking, as I say, even without direct rulemaking or getting bills passed, are having an effect, as I said, with drug companies announcing some price rollbacks and some other interesting things that we haven't made public comment on, but I think are probably happening because of the things we've been doing. So
Yeah.
there's actually I just read about a group that's going to stand up a non-profit generic drug maker to introduce generic competition into markets where there's single source generics. And they didn't say it, so I shouldn't, I can't declaratively state it, but Scott Gottlieb, the commissioner of the FDA, has been very clear he wants to see more competition where there are single source generics. So the pharma boys like Martin Shkreli can't get away with what they're doing. And he's communicated that very publicly, and the FDA is reforming its regulatory procedures to encourage and prioritize new generic drugs where there's only a single source. And I can only reasonably conclude that folks who just said, hey, we're going to invest in setting up a nonprofit generic drug maker would have been responding to the kind of incentives that Dr. Gottlieb has been proposing.
What is the biggest thing that you have experienced here in Washington State that maybe you didn't foresee when you first took this job? You spent a year, as you mentioned, back in D.C. You got 4 different states plus over 200 tribes. What's sort of unique that you didn't see coming about Washington?
Well, I think, the obvious answer is that people are very excited about, your ACHs, and there's a lot of people who are recognizing that you've invested a lot in that over the 5-year period, and you want to know what the next step in that is. And, I've been learning a lot about that to kind of, even just recently, I've been meeting a lot of folks who've been talking about that and are concerned about that. We don't want, it's a complicated healthcare system, and there's a complicated level of governments there, right? There was a recent, is John Hammerland here from CMS? I don't know if I see him in the crowd yet. I know he's speaking to you this afternoon, so he'll be able to give you more technical details on Medicaid and Medicare. But, we want to see more state innovation. We don't think the federal government knows best. We think individuals knows best, and the state is the closest level of government to the individual. So we want to give waivers. We want to be responsive to innovation. There are statutory constraints on what we can do, and we always are looking for a way to say yes. And I know CMS is always looking for a way to say yes. I know we're still working on the Washington State applied for a Medicaid waiver on the dental health aid technicians, and we determined that waiver would have violated civil rights law because the opportunity for that people to make use of the dental health aid technicians would have been only in Indian country and not for all residents of Washington. So CMS is still looking for a way to I don't know, how would you say that, get to yes, and I know there's still discussions with the state on that. So, we want to say yes to as much innovation as possible. Certainly, I spent a lot of time. I'm so grateful for you inviting me here because, it gives me, when I'm invited to speak, it means I can justify a travel budget back to DC. So they don't seem to understand that this region is Washington, Idaho, Oregon, and Alaska. Yeah. So, for me to get on a plane and fly out, for everywhere I want to go, sometimes I get, resistance, right? Yeah. So when I'm invited to speak, that smooths the resistance. So then I take the opportunity to go out and visit institutions and folks. So yesterday I spent some time at a hospital system here who I don't see on your list of sponsors, so I won't say their name. But anyway, it was a great visit. And so whenever I'm in an area, I'd love to go visit, actually see things on the ground and learn from. We were in the NICU and looking at babies that had been born, some with neonatal abstinence syndrome, other preterm, and talking to the intensive care nurses there. I learned so much,
Yeah. You can say their name, whether they're a sponsor or not. There are only two of them.
Oh, yeah. Well, it's Providence St. Joseph. Yeah, they've figured that out. Yeah.
And I should just say, too, I should apologize to you because we talked about having you speak for 15 minutes and then you and I doing Q&A for 15 minutes, and I just rolled you right into
You went right into Q&A. Yeah.
So, thank you for preparing remarks. I want to also let you roll right on into questions from our audience. If you have a question, just raise your hand and we'll get a microphone over to you. Don't be shy. And we got one on either end. So it looks like we've got a couple right up here. And we start right here. And then we'll go over here. And then we'll go over here. So why don't you tell us first your name and your organization and then take her away.
Good morning. Nice to see you again, John.
There she is. Oh, no.
My name is Peg Curry. I'm the Chief Executive for Sacred Heart and Holy Family and Chief Operating Officer for Providence Healthcare in Eastern Washington. It was great to have an opportunity to show you the hospital at Sacred Heart yesterday. So thank you for your visit, first of all. Secondly, I know that people, when they think still of healthcare, they think traditionally of healthcare, and they think of hospitals and clinics. And as we transition more to a less geographically constrained healthcare world with digital technology occurring and having access in ways that are more virtual, it makes me think a little bit about and my question is, what are the initiatives that maybe are a little bit more long range, trying to get upstream of healthcare instead of downstream in the most acute settings, in terms of people's accountability for their own healthcare, their personal healthcare.
Great.
Thoughts on that would be appreciated.
Absolutely. Thank you so much. And thanks for, the light's shining in my eyes, so I didn't see you there. So if I'd seen you there, I wouldn't have demurred about that. I had such a great time at your hospital. And Linda was so great in the NICU, and she was fantastic. And I learned so much. It was, they were a little nervous about bringing me in there to see the little preemies, but, they thought I would trip over something, but it worked out great. And they're so committed there, and the other things I got going on, but I'm not here to talk about the great stuff you're doing, but, how we can respond to that. So there's, agreed, I guess would be the first response. One of the things, I'm just trying to think of some specifics here. So one is paying for housing and transportation. Now, when I was talking about, traveling with my HUD counterpart and, trying to figure out how you folks are putting streams of funding together, as they funnel from the federal through the state, county, and local and the various agencies and districts and stuff, that we want to streamline that and make that more efficient. So when you identify social factors or social determinants of health and where you're having an impact, that there's not a barrier to us funding that. I mean, that's kind of one kind of principle that I think Medicare and Medicaid is on. And, we've seen that in the Medicare Advantage plans now can pay for transportation. And I'm trying to think, I don't have them in my talking points, so I don't want to overspeak what the rule is. They put out these 1,000-page rules and they expect me to memorize them. But there's other things. Let me get to a couple of other sort of specifics. So one thing on drug pricing, one of the things that the FDA has put out guidance on moving drugs to non-prescription status. And there's going to be rulemaking come out on that. And so how do we ensure that the safety and efficacy is not jeopardized if, say, there's an over-the-counter naloxone proposed or an over-the-counter cholesterol-lowering drug proposed, and the FDA wants to respond to that application? Well, one way that they've proposed in their guidelines is, so there's an app on your phone, can we kind of give you, and again, we're not, the guidance doesn't overly specify because we want the sponsors to come forward with solutions, but suppose there's an app on your phone and you can answer questions on the app, kind of like self-testing might be a way to put it. And so you demonstrate to us that you have a level of understanding that for you, maybe that drug as an over-the-counter product, you can take it without risk. That's one way to look at it. Another way to look at it, and again, it's not necessarily technology, but it's the question of price transparency. The way the president looks at it and the way the secretary looks at it, we are not interested in people saying market forces don't work in healthcare. They don't work in healthcare because we don't let them work in healthcare. And what we're trying to do is move that needle. So we're insisting on price transparency. Dr. Gottlieb at the FDA has said he's looking at a way, and again, this may not be within his power today. It may require legislative amendments to, on the advertising of direct-to-consumer prescription drug advertising, put the price on there, and that will trigger a consumer response. At CMS, Seema Verma is insistent that she wants to see price transparency within the Medicare program. Patients need to know what things are going to cost them. And, this idea that you go to a facility and you don't know how much it's going to cost, CMS is going to put a squeeze on that really soon. And that's really going to help. Sorry, I'm sort of drifting off the question because this is a real passion of mine, and I know it's passion of Secretary Azar's, but this price transparency kind of, we want to see progress on that. And I think Medicare is going to really squeeze that. And that's going to make more informed consumer choices. And if the consumer knows, if I do preventive care, that's going to cost me less than waiting down the road, at the margin, that will have some impact.
Let's go for a question over here.
Wade Larson with Wagstaff. I'm representing the employer side.
Great.
Anyway, rather than whine about the cost of healthcare, we think that healthcare reform begins at the local level. And so this is the way we think. The biggest driver to cost is claims. And, if we can help our employees be better consumers and make better choices and also to get healthier, then they're not going to incur as many claims. And so we incorporate both cost control and wellness, and that's what's helped us to drive. And to be honest, that's what's helped us to save over $1 million a year on healthcare. And so that's how we do it. But I got to tell you, as we engage our employees, this is where we get frustrated, is when we get cases like the EEOC and the AARP case. And when I reach out to folks, our representatives, and I'm getting nothing back, to say, hey, help us out to get some influence on the EEOC case, on the wellness. We only have a handful of tools that we can use. And so when we're talking about the wellness incentives, with the potential of going, multiple ways, that's where I'm reaching out. Not so much a question, but a request. We're going to need some help, because we only have so many tools to maintain those motivators.
Yeah.
And on the one hand, we can do so many things like carve out. We can carve out some things, but we don't do that, and we work with our employees as partners. And to be honest, we have a 98% satisfaction rating on our benefits with our employees. So they're enjoying it, they like it, they're engaged, and like I said, we're having some great success. And if we lose those tools, we're going to lose the ability to control our costs and make this affordable to our employees.
Yeah.
So anyway, to that point, I guess that's our request, is what can we do to help maintain those tools?
Right.
We're reaching out.
Okay, so and that's great. I'm so glad to hear from the employer community, because our role in the employer community is not that great. The Department of Labor is more, and the states are more, and you got ERISA and all that stuff. But we have some role to play in the employer-based health, since the Affordable Care Act in the small employers. But for large employers, I'm happy to learn, whatever you have to contribute, because we know that employer-based system has been able to achieve success that we have not yet achieved in the government-run system. And price transparency has to do with a lot of that. Employers, in many cases, are doing more, the reference-based pricing on the joint procedures. There's some examples from, CalPERS in California on that. We've also got some studies that we're looking at. We're hoping we can replicate them in Medicare and other programs One of the largest studies on this price transparency issue looked at more than 500,000 patients whose employers built a price transparency platform to inform them about the cost of various healthcare services. And when patients used this platform to research prices, costs dropped up to 15% lower for lab tests and up to 16% lower for imaging. So these are things that employers are doing, and we want to learn from employers and implement them in our systems. So thank you so much.
Do we have a question over here?
Good morning. Torney Smith, Spokane Regional Health District here in Spokane. Thank you so much for being here. As the data shows, we all definitely want to have quality health care when it's a need. But if we talk about health of our population, that only attributes to about 20%. The other 80% are what you alluded to earlier, the social determinants of health, the issues of inequity that exist. And yet, from a federal government perspective, we continue to reduce the Prevention and Public Health Fund. And I don't understand the association between what the data tells us and what we are prioritizing in our funding.
Do you want to respond to that insofar as what things the administration might be able to do, either working with Congress or on its own, to support addressing social determinants?
So in terms of actual funding, we have very little to do with that. You know, Congress appropriates, and so, you know, the president has his budget, Congress appropriates, and, you know, I'm happy to discuss the president's budget to some degree. Whether that would be useful or not, I don't know.
Yeah.
We're coming up to September 30th, and I don't even know, you know, what they'll be funding us at after September 30th,
That's the end of the federal fiscal year.
Yeah, I'm going to say it's even broader than that, in the sense that sort of the general bias of our administration is that being employed is good for your health status. And so we're, as you know, employment's really good nationwide, and we have a strong economy. So, you know, we think that's a step in the right direction. And I appreciate the question, and I'll reflect upon it, and I'm happy to speak to you personally about it. And
good.
You know.
Torney's one of the more respected healthcare leaders in the Eastern Washington. Over here.
Good morning, John. When you said you were from Canada,
Over here.
When you said you were from Canada, I recognize that I have met you before. My name is Linda Parlett, a former state senator, and we, with some other Senate colleagues, went to Canada to visit you, probably in 2003 or 4 or somewhere.
Oh, yeah.
So I have a request to you. As a registered pharmacist, I just wanted to share with you that Washington State was the first in the nation to provide provider status for pharmacists. And I realize that this is a congressional issue that has to be dealt with for Medicare in the future. But because you're talking about transparency and over-the-counter things like that, I would like to talk a little later with you for about 3 minutes, so you can be fully educated in case some of those people who represent us in Washington, D.C. need to know the value of this, because I can be a big salesman on this. Thank you.
That's great. Thank you. It's good to see you again, or sort of almost see you again through the lights, but that's okay. And it actually reminds me, one of the things I hope the pharmacists are happy about it is CMS has proposed removing gag rules that the Plan D sponsors, you know, the Medicare beneficiary might pay less out of pocket if they just paid a cash price at the pharmacy, but there was a gag rule that the Part D plan sponsor put on there, so the Medicare beneficiary pays actually more out of pocket than they would have without that gag rule. So that gag rule is going to go away if Seema Verma has her way. So thanks for bringing it up.
I would just, having been fully educated by the former senator during her legislative days, I would just warn you that could be a powerful 3 minutes. Yeah. Other questions? Right back here, I think, or over here, whoever's next. Just get a microphone. Whoever had their hand up first, sir. There's one right here and then one over there.
Good morning. My name is Ashley Sutton. I'm with the Economic Opportunity Institute here in Washington State. We're a nonpartisan think tank. And part of my work has been traveling across the state of Washington and meeting with constituents to hear what their interactions are with the healthcare system. And so this question is really related to the current stance on opioids. And one of the things that I heard actually last night in Spokane with meeting with constituents was the fallout from this opioid policy. For elderly people specifically that have been using the opioids for pain management for 15, 20 years. This hardline policy has made it to which now they're in a place where they're not able to get the drugs they need to be able to function every day. They're not able to go to work. Most of them are on Medicare, right? And so now they're not able to get their drugs.
Mm-hmm.
And their quality of life has suffered, and they're not able to be productive citizens in their community. So I'm wondering what dialogue has transpired, if any, surrounding how we can help make sure that these people have a high quality of life.
Okay, thank you. So you're talking about the Medicare policy on the Medicare beneficiaries, or the...
I'm alluding to how this hardline opioid policy where prescribers are hesitant, reticent to prescribe, the direct impacts on our population.
Yeah. So I think I'm going to say that we've had a lot of, I don't want to wind around the question, but I have to be careful. I'm not a doctor, right? So we have seen success over the years in reducing inappropriate prescribing of opioids. One of the causes of the opioid epidemic is prescription opioids that, boom, they go out there and who knows where they ended up, right? So that's what we're trying to get a grip on. The chronically ill, I hear what you're saying, and I meet with oncologists, I meet with pain specialists. Let me try and be helpful in my answer. The venue to communicate that concern really well is there's a federal advisory committee that was stood up at the as a result of the Cures Act that was passed in December 2016, and we call it the Pain FACA, the Pain Federal Advisory Committee. So it's got both government members from HHS, from Department of Defense, from Veterans Affairs, plus members from the private sector, practicing community. It's chaired by Dr. Vanilli Singh, who's the Chief Medical Officer at the Office of Assistant Secretary of Health. And she's a pain specialist from UC San Francisco. And we hear that concern, and we definitely want to make sure that any restrictions or any policy on opioids does not make it cause the problem that you're creating. So we have heard that concern from many sources, and I'm going to hesitate because I'm not a doctor, so I'm not going to give any medical opinions on this, but we are cognizant of it, and we will be responsive as things go forward. I'm also, again, I keep talking about the FDA, and maybe people don't think about the FDA a lot, but that's another priority, looking at non-addictive alternatives, prioritizing them for approval. So, I mean, that's not short-term, that's long-term, but that's another thing I'd ask us to keep in mind.
You're sort of here as the ambassador from the Trump administration to the healthcare community, but you also play this role of being ambassador of the 4 states back to HHS. How do you take concerns that you hear here and convey those back to DC? Well,
I write them down, and I write reports. It doesn't sound very exciting. Yeah. It sounds like a bureaucratic procedure, but the structure is there are 10 regions, and you're having your meeting in Los Angeles next week, right? And my colleague from the San Francisco office will be there. So we meet and we confer with, as the group of 10 of us confer, and then we fly back and meet. We'll be going back on October 2nd, 3rd for 3 days, and we'll be meeting with the Secretary and Deputy Secretary and the Seema Vermas and the Scott Gottliebs and all that, and so we'll be discussing all the stuff we brought back. It might sound a little more organic, but I prefer it to be organic like that than bureaucratic. So I'll just take a second to describe the structure, because what the heck's a Region 10, right? So we got these 4 states and the tribes. We have about 900 employees here, of which 700 are in the Indian Health Service, actually in hospitals and clinics, mostly in Alaska and stuff like that. CMS got almost 100 people here. All the other operating divisions have people here. So they have their chains of command that go up, But if you're trying to affect change in this tiny business of 80,000 employees and $1.3 trillion, you have to hit a lot of pressure points. So really, I'm another pressure point you can hit, You can also hit your colleagues in the various operating divisions that you work with. I'll give you a specific example of the opioid epidemic, and again, I don't think I satisfied the gentleman who asked about the public health response, so I'm going to try and give a good example here. We formed an opioid regional learning collaborative which has got to be a government setup because the acronym is ORLEC, right? So only the federal government could think of an acronym called ORLEC. And the Opioid Regional Learning Collaborative is me, the senior staff from the operating divisions, Centers for Medicare and Medicaid Service, Substance Abuse Mental Health Services Administration, Office of the Assistant Secretary of Health, which is the public health branch, Agency for Children and Families, Health Resources Services Administration, the community clinics and workforce folks. So, and that we convene with their peers from the 4 states and from the tribes. Within the Learning Collaborative, there are response groups. So there's a public health action response group, which is led by our regional health administrator and her peers from the 4 states and the tribes. There's a Medicaid action response group, which is the guy who runs Medicaid at the federal level in the Seattle office, and his colleagues from the states and tribes. And behavioral health, human services, all that. So that's one way in which we kind of organize ourselves to take in input. And I'm kind of telling you that to make sure that as you're talking to the state folks, I just want to make sure you're aware of it, and so you can put pressure on them as they come to the meeting to bring your concerns forward.
So we're running out of time. I want to give you an opportunity to sort of culminate this in maybe counsel to this group of healthcare leaders, counsel to them about how best to engage you as the point person for the Trump administration.
So the best way is very simply invite me to speak and take me on a tour of your facility and meet your people who are actually doing things on the ground, like the NICU nurses. You know, if I'm standing there talking to a NICU nurse with a premature baby and you're telling me about what's going on with neonatal abstinence syndrome, I'm going to listen, right? So I love touching equipment. As long as it's not attached to a patient, that would be dangerous. But, you know, so just please get me out there. And like I say, September 30th, I don't know, I may be on a week-to-week funding, depending on what Congress does. Maybe you can ask your lunchtime speaker how that's going to work out.
I will bring that up. Are you able to stick around here for a little bit and continue to take questions from our audience?
Yeah, I'm happy to do whatever you need me to do.
Great. John R. Graham,
Thank you
very much for joining us. Let's give him a round of applause. Thank you, sir.